Thank you for the organizers for inviting me and allowing me to speak today. It was a fantastic panel and appreciated hearing the different viewpoints on what we need in Biothreat and new pathogen detection platforms. I'm going to talk to you today about what we have at T2 Biosystems. We have a new technology that detects directly from whole blood and other types of matrices without the need for upfront culture. And this is ushering into the clinical arena a new type of paradigm for treating and diagnosing patients. And I'm going to take you through that. I'm going to take you through some of the clinical data, and I'm going to take you through some of our data that we have that show that we can deliver a biothreat pathogen detection panel and talk a little bit about how that might fit into the clinical care of patients. To start off, I just want to talk about the interplay right now, particularly for patients that come into the hospital. They have a fever. They may already be in the hospital at the ICU and got a hospital-acquired infection, and it's uncertain what's causing the infection, and specifically for bloodstream infections and deep-seated infections. Today, what we do with those patients really depends on the diagnostic technology that's being used. And the diagnostic technology being used for these patients is blood culture. So the blood samples are taken from the patients, they're cultured. It takes a significant period of time to get to a positive culture. And once there's a positive culture, then there's rapid technologies, whether it's MALDI, whether it's BioFire, or other types of technologies to detect the pathogen that's in that positive culture. And that actually has a big influence on patient care. Today, because of that time waiting until getting to a positive culture, patients are put on empiric antibiotic therapy. And the threat of bloodstream infections is so severe that even though only about 10% of the patients who are suspected of a bloodstream infection are actually positive, you have 60 to 70% of these patients getting put on empiric IV antibiotic therapy. And what's really mind-blowing about this paradigm today is that if you go and ask, well, of the patients who are actually truly infected, what percentage of those patients are on appropriate therapy? The number is about half. So even though we're overusing antibiotics, IV antibiotics today to try to address this problem, we're not getting them on the effective therapy quickly enough. Now, the great news is that once species identification is available, the data show across many studies that actually over 90% of patients are on effective therapy. So if we can get patients the diagnostic result of species ID far earlier, then we have a good chance of getting the majority of patients that are infected on effective therapy. And that's what we're dedicated to at T2 Biosystems, is delivering that species identification and resistance gene information very rapidly. The other sort of challenge here is that it takes multiple days to get to that final antibiotic susceptibility test. And there's a significant proportion of patients, particularly those with carbapenemase resistance gene infections, that actually pass away before the result even becomes available. So there's a significant challenge here, technical challenge, to deliver tests that are direct from blood that can provide these results in a culture-independent manner. Why does this matter in terms of speed? So if you have a bloodstream infection, your odds of death for every hour that you're not on effective antibiotic therapy go up by 4%. And if you enter septic shock, then your likelihood of survival is decreasing by almost 8% for every hour. So there's a substantial criticality to being able to get that information very rapidly, and that's why antibiotics are used so prolifically in these patients, trying to get them on the right therapy as quickly as possible. So the opportunity for hospitals that are using the T2 magnetic resonance platform, the opportunity for them is to be able to have the species identification information far earlier, and then soon with the launch of our resistance panel that'll take you through, actually have resistance gene identification far earlier. And then delivering the proportion of patients we expect to be able to see once you have these results back is around 90%, or upwards of 90%, 95%. And that's what the data show today. Once that information is available later in the progression of disease, that's how many patients are on effective therapy. So the panels that we have two panels that have been FDA cleared. Both of these panels, so T2 Candida and T2 Bacteria, they actually are first-in-class panels. That means that actually a new product code was formed by the FDA when the panels got cleared, because they're the very first direct-from-blood panel for fungal pathogen infection. That was the T2 Candida panel. Or for bacterial pathogen infection, that's the T2 Bacteria panel. We have a T2 resistance panel that actually identifies directly from blood resistance genes, also the same kind of analytical sensitivities of all our panels, down less than 10 CFU per ml directly from blood. And then we have a couple other panels, Candida auris I'll tell you about, as well as our T2 Lyme panel detecting Borrelia directly from a patient blood sample. So the instrument itself is fairly simple to use and straightforward. It's fully automated. You basically take a 4 ml EDTA vacutainer, attach it to a cartridge, put the cartridge on the instrument, and walk away. And then everything that needs to be used to process a sample is on that cartridge, and any waste that's generated is on that cartridge as well. So everything goes on and off with this cartridge that's used for the testing. You can see sort of a schematic of the loading process, and then you hit the touch screen to go. You can load up to 7 cartridges at a time in a random access fashion. So it's been designed so that the time urgency of each patient can be respected by allowing rapid loading of those samples on the instrument. You may ask, how does this work? How does it work under the hood? So I'll give you a brief overview here, and happy to go into details as folks are interested. So the enabler for our technology is this thing called T2 magnetic resonance. If anyone's familiar with MRI or you've had an MRI done, you've probably had what's called a T2 weighted image done. That's a measure of the physical property of particularly of the water molecules in a sample. And we have tied that signal to the presence of pathogens. And that's through nanoparticle binding agents that we have that actually cluster to target DNA that's present due to the pathogens there. The way this actual workflow works is there's a 4 ml vacutainer that's put onto the cartridge. The instrument takes 2 mLs of that blood, and it actually does something that's very counterintuitive for molecular diagnostics. It concentrates all the debris, all the intact pathogen cells, all the human genomic DNA, and discards the supernatant. And then we do all of our processing in that gamish of material. So you have your intact pathogen cells, you have 60 to 80 micrograms of human genomic DNA and everything else. We do a lysis step, a very mechanical bead beating step that lyses the pathogens, and then we do an amplification step directly in all that material that typically interferes with conventional PCR methods. And then the amplified product we detect with a highly sensitive detector, the agglutination reaction that we use for T2 magnetic resonance. And so this has enabled us to develop all these pathogens, this workflow on the instrument, all the panels that I'm going to take you through today, as well as the Biothreat data that I'll take you through. Just a brief summary of the clinical data. There's over 24 peer-reviewed papers now on the clinical use of our tests. And using these tests, the T2 Candida panel was cleared about over 4 years ago, T2 bacteria panel about a year ago. And the data that have come out have shown that it's definitely much faster than culture-based methods. 5 hours versus 72 hours. You can actually get patients on effective therapy much faster as well, so an 8-fold reduction in time to effective therapy from 44 hours to 5 hours. Our clinical sensitivities and specificities are all in the ballpark of 90 to 98%, approved across many multi-center studies. MPV and PPVs are very high. Of course, PPV depends on the patient population that you use the test in. And then implementation of T2 Candida, it's been out in the field long enough now that we're seeing clinical utility data around economics, length of stay, savings, and so forth that's very favorable. And then T2 bacteria, I'm going to take you through a couple case studies now, and the evidence is now building, demonstrating strong clinical utility for T2 bacteria, and I'll take you through a few of those cases. But first, you may wonder, why is he talking here at the Biothreat Pathogen Detection Conference and Biodefense? So there's a strong interest in being able to enable hospitals to be able to not only survey but identify patients that have infections from known threats. DHS has defined what those pathogens are, and I'll take you through the panel that we've demonstrated feasibility for. We have a growing number of placements around the country and around the world of these fully automated instruments that allow ultra-high sensitive detection directly from blood, as well as from swab eluate and other dialysate and other types of matrices. And so there's a lot of inbound interest in our work to be able to enable surveillance and detection and triage of patients who are at risk. If you rely on blood culture, you're going to have a problem where your patients are not identified early enough. You may need to actually be using quarantine and other infection control procedures for those patients, not to mention making sure they're on effective therapy. I think one of the dire things about the blood culture-based diagnostics is that about half of the patients actually aren't appropriately detected by blood culture in adequate time. And so if you're missing patients with blood culture and you're looking for one of these biothreat pathogens, we have a serious problem in our hands. So these 5 different species we have data for now in terms of detection of the target DNA from anthracis, Burkholderia, Rickettsia, Francisella, and Yersinia pestis. And basically at this point we're at the beginning of what can be a product development pipeline for us that can develop a biothreat pathogen panel with the same characteristics of the 5 other panels that I've described to you, getting down below 10 CFU per ml, and that's equivalent or better sensitivity to culture. I'll take you through a bunch of that data for our other panels. So we're really excited about this capability and then the opportunity to be able to help provide a tool like this One of the great things we've seen is customers have taken our panels that we've developed for whole blood in septic patients, which when you have a septic patient, blood samples can vary pretty dramatically. It's very easily validated for other types of sample matrices, whether it's environmental samples, urine samples, dialysate, or swab samples. So I'm going to go through a couple examples of studies that have been done on T2 Canada and talk about how that applies to the clinical use broadly of the technology. And so as a diagnostic company, one of the things that we focus on is first demonstrating accuracy and meeting the FDA's bar to get FDA clearance. And because we were the very first test to get clearance for direct from blood without the need for an upfront culture, there's a bar that's been set that we needed to meet. So in our diagnostic accuracy study for T2 Canada, we demonstrated very high sensitivity and specificity. However, there weren't a large number of patients that were blood culture positive. It's hard to get those patients in these types of studies. And so there was a study, the follow-on study shown here, published by Neil Clancy, that got 152 candidemic patients and demonstrated that the sensitivity of the test was indeed at around 90%. 89% was the number that they measured, and 91% was what our accuracy study measured. So a nice validation of the original FDA-cleared study. The other thing that this demonstrated is one of the challenges of doing accuracy studies in patients that are possibly antimicrobial therapy as blood culture has an interference problem with antimicrobial therapy. That therapy can actually inhibit the growth of your pathogen that you're trying to detect. And so you get culture false negatives, and you happen to get positives on T2. And so understanding that, there's been a lot of data now that's demonstrated that explains a lot of the T2 positive blood culture negatives that we observe. Another study, this was a clinical utility study demonstrating the value of T2 Candida in patients suspected of candidemia, so at risk for these bloodstream infections. We had a seven-fold reduction to time to effective therapy for these infected patients. And we're really excited about that at T2 because that's the thing that really drives the value of the test, is catching these patients that are at severe risk. However, what was also fascinating about this study is before they implemented the T2, they were only detecting about 57% of their patients that had candidemia. The other ones were going undetected. And with the T2 system, then they were detecting 93%. So that's that delta of patients that are getting missed when you don't have ultra-high sensitivity diagnostics and you're relying on blood culture. Another observation from this study was shown that actually ocular involvement of candidemia decreased significantly once they implemented a diagnostic. And the hypothesis is that the dissemination of the disease was actually kept in check because you're getting patients on appropriate therapy earlier. There's been a variety of other studies that looked into cost savings. Of course, in the hospital systems today, you've got to show that you can be economically beneficial to the hospital. One of the uses of our test is actually withholding unnecessary therapy. As I started out saying that we're overusing antimicrobials severely today. When you have a test with a very high NPV and a good antimicrobial stewardship program, that's the opportunity to actually withhold therapy. For the Canada panel, it's been demonstrated in multiple studies and institutions, savings of about $200 to $500 per tested patient after the cost of our test, the price of the test. Another area, we've had a hospital actually receive a quality award to the lab because their reduction in length of stay due to the use of T2 Canada. It demonstrated they had a couple $1 million of annualized savings because they were using this test to catch patients earlier, get them on effective therapy, which then would lead to a lower length of stay in the ICU. I'll shift gears and go to T2 bacteria. For the microbiologists in the room, you'll probably notice right off the bat it's not all bacteria. Probably the better name for it for us microbiologists would be the T2 escape panel. It actually detects the escape pathogens that have been deemed such because they typically escape appropriate antibiotic therapy. So if you have Klebsiella pneumoniae, Pseudomonas aeruginosa, E. coli, you have a high likelihood that you are not going to be responsive to conventional first-line antibiotics. And so we wanted to deliver these results for these types of pathogens first, and then, of course, as we proceed, we'll add more pathogens to our panel. So the T2 bacteria panel, we recently published the pivotal study data. I'm really excited about that. It was a very large study, 11 centers, over around 1,500 patients. And that, once again, was an accuracy study to evaluate how accurate the test is as compared to blood culture and to allow the FDA to determine if it was safe and effective for clinical use, which they did determine by its FDA clearance. Sensitivity is in the ballpark of 90% here. In the pivotal study, we didn't have a large number of positives. Once again, it's hard to get infected patients in these studies. But the specificity, which was very important, was very high, on average about 98%. One of the things that we're really excited about, a big question about bacteria, when folks saw the Canada panel, they said, okay, that's fine and good. Of course, it's much faster than culture because fungal organisms actually culture really slow. But E. coli and these other pathogens have a very high quick doubling time. And so the output of our pivotal study showed that the T2 result, of course, it's coming on the average around 5 hours, and the actual culture time to species ID was about 70 hours. So substantial time difference even for these organisms. So when you have a patient that's septic, they have a dilute, a titer level, and they may be on antibiotics, that culture time is still very substantial for that patient. And once again, every hour matters. If you have a bloodstream infection, every hour without effective therapy, your odds of death go up by 4%. So the time savings of about 70 hours is substantial for these patients that are infected with these pathogens. The thing that's really fascinating about the clinical data in these types of studies is the T2 test is detecting more positives than the blood culture test. And then what usually happens in that discordant results analysis, and it did in this study, was asking the question, were those patients truly infected? And the majority of cases that was demonstrated to be true with proven results in our pivotal study. So we had about 3.2, so about threefold more positive with T2 than with the companion blood culture that was drawn at the same time. But then by going to other cultures that were drawn at other times from the patient, we're looking at other types of diagnostic results, we're able to demonstrate that those patients were truly infected. And when you think about sort of a paradigm where you need to screen patients that have general symptoms, you want to catch patients with the biothreat pathogens as quickly and sensitively as possible. We think that this technology provides that. And you ask about therapy. What about these patients in this accuracy study? Were they on effective antibiotic therapy? And so of the patients who were actually infected, shown to be infected, you had 69% of them at the time of the blood draw were not on effective antibiotic therapy. 24 hours later in time, now the T2 result's not available to clinicians during an accuracy study. That would not work for an FDA submission. So just based on the standard of care, 24 hours later, they had 80% of the patients on effective therapy, so 20% not. So still, 20% of the patients were not on effective therapy. I hope no one in the room here has a loved one that suffers from sepsis, but the odds are about 1 in 5 of us will be touched by sepsis in our lives. And if you do, one of the number one things is, do you know what the infectious pathogen is? Do you have them on the right therapy? The other dimension here, a study just came out from one of our customers demonstrating the utility of withholding unnecessary therapy. And you may wonder, why does that matter? Why don't we just put everyone on every possible therapy? Well, you've got all these different therapies that cover different pathogens, some broader than others, but a lot of these therapies are nephrotoxic. And so when you have a complex patient that has issues, you don't want to be putting them on unnecessary therapies. Not to mention the problem also with the emerging of resistance due to the overuse of antibiotics. In the emergency department, we have some very fascinating data, and I think this is where a biothreat pathogen panel would actually end up being used as you screen incoming patients. The T2 bacteria panel, that's the primary area of interest by folks that are looking into the panel and implementing the panel and have already implemented the panel, is using them in the emergency department. In the emergency department, you don't have patients on prior IV antibiotic therapy, so the number of discordants decreased significantly. We have 100% sensitivity and over 98% specificity in this multi-center study here that was presented at a previous conference and is now in peer review. But the fascinating thing is, once again, you have about a quarter of the patients could have benefited from what's called species-directed therapy, and then another third of patients could have benefited from effective therapy. So of the infected patients, there's a significant opportunity to provide that results faster and have an improved therapy outlook for the patient above and beyond the empiric antibiotic therapy. I want to take you through some case studies just to give you a flavor for what this is like when you implement a test like this in the antibiotic therapy. So this is a customer that's using our test interventionally on patients, and this patient was actually receiving dialysis, was unresponsive, and developed sepsis. They were started on a common combination of antibiotic therapy, vancomycin and what's called Bethesda. Provides pretty broad coverage. The T2 test came back positive for Klebsiella the T2 test came back positive for Staph aureus and negative for all the other pathogens. Blood culture at a later point in time came back positive for Staph aureus. However, because of the T2 result, they de-escalated the Bethesda, the unnecessary antibiotic therapy, which is nephrotoxic, can damage the kidneys, right off the bat with the T2 result, making that therapy decision. Another example of using T2 bacteria interventionally is a nursing home patient, had aspiration pneumonia, started on vancomycin, ceftazidime, and clindamycin. The T2 came back positive for Klebsiella pneumo. Blood culture actually never came back positive for this patient. So this is a classic example of what they call blood culture negative sepsis. They know the patient's septic. They don't know what pathogen the patient's infected with. In this case, they treated based on Klebsiella pneumo from the T2 bacteria result, put the patient on meropenem on IV. Within 5 days, they were able to transfer the patient back to the nursing home. They're very excited about being able to capture a case of culture-negative sepsis. The last case study I wanted to show you, in the emergency department, one of the challenges is triaging a large number of patients and understanding what to do with them. In this case, this institution was using our test observationally as their first step in clinical implementation. In that case, they use the test, they get the results, they don't release it to clinicians, and then they do a post hoc evaluation of each case and say, could that have added value to the clinical care of the patient? So this patient came in with signs and symptoms of a UTI. There was a blood culture drawn, a T2 draw that was taken, and a urine analysis was done. The urine analysis indicated the patient didn't have a UTI. And so they actually had started the patient on IV ceftriaxone, so IV antibiotics, right off the bat, just out of caution. But because the urine analysis came back negative, they discharged the patient, sent him home. The T2 result was not available for clinical use. They batched those, ran them at the end of the day. 11 hours later, they got the result, but they couldn't share that with the clinicians. The next day, blood culture comes up positive for E. coli. What do? They call the patient back in, say, we need to admit you and treat you. And so this is an avoidance. The T2 bacteria would have helped avoid the discharge, unnecessary discharge, and readmittance of the patients. That's something you definitely want to avoid when you have a patient infected with a biothreat pathogen, and frankly, any pathogen. That's something that we're excited about for the T2 bacteria panel. So I'll shift gears and talk about our T2 resistance panel. So once we demonstrated the performance of the T2 bacteria panel and shared that information with folks, then the refrain from the community that we work with was, well, can you do that for resistance genes? And we're really excited now that we have data showing that we can detect gram-negative and gram-positive resistance genes at the same sensitivity that we can detect pathogen species and report those results with the same kind of turnaround time. So there's 13 resistance genes on this panel. We're in the 2 to 5 CFU per ml limited detection data. And the panel itself is, once again, it's direct from blood, no need for upfront blood culture. And we've got a lot of great data now demonstrating no cross-reactivity and all the same robust performance data that we have in our other panels. So for example, on T2 bacteria, we've got really nothing inhibits the test other than an MRI contrast agent. Same thing here. So the data that was just presented at ECCMID was the first clinical data of a direct from blood test detecting resistance genes in patients. There was 2 hospitals in Italy that participated in this study. I'm not going to go into all the details. Just the time to result advantage on average across all the patients was 25 hours earlier with the T2 result compared to their standard of care. And then the longest case is actually a 95-hour difference. So there's a lot of excitement about this. They were identifying KPC resistance genes right out of the blood sample. So we're going to be launching this in Europe before the end of the year. And then in the US, we'll be launching as a research use only test to foster studies and clinical data as we progress towards FDA clearance. So this has been what's called a breakthrough designation from FDA that allows us to interact with the agency more proactively and help pave the way for clearance here in the US. I wanted to touch on Candida auris. I think it'd be interesting to the audience here. So I'm sure you've seen recent newspaper articles about Candida auris, this emerging multidrug resistant pathogen. It's a fungal pathogen. It's able to live on surfaces, unlike a lot of fungal pathogens. It actually shut down an ICU for many weeks in England. And so there's a lot of concern about this. The CDC's been doing a great surveillance program, and they approached us a couple years ago and asked us, they presented their problem was they'd receive these patient swab samples. They'd be swabbing the patients in the axilla and groin, and they'd send them into the CDC, and the CDC would be evaluating if the patients were colonized with Candida auris. Now, the issue here is it took 14 days to culture these swab samples, and then afterwards to do molecular and mass spec and other workup sequencing to determine, is this Candida auris, what clade does it belong to, and so forth. Well, the hospital has no feedback at that point to be able to quarantine the patient, make any decisions. And so we've been watching. If you go to the CDC, they have a great website reporting the number of cases continue to grow in terms of Candida auris infection and colonization. And so they published a paper where they took our technology and showed that they can get very nice sensitivity and specificities. The actual limit of detection was over an order of magnitude more sensitive than any PCR test, and they could get results in that 3.5-hour time frame directly from our instrument in a fully automated fashion. So we're excited. We're in discussions with different hospitals looking at validating this test for their use in the US and outside the US. T2 Lyme panel. If you live up in the Northeast, everyone knows what Lyme disease is, and we're all afraid of it. And I've been finding ticks on my kids already this season. The Lyme panel, we have a multi-year clinical study going on right now. And the initial focus with our work and with our conversations with the FDA was on diagnosing patients that have a rash and determining if they have Lyme disease. Now, it turns out that those patients aren't in a dire need of a diagnostic. If you have a rash from a spider bite or a tick, you're going to get doxycycline. It's the patients who have the Lyme symptoms that don't have a rash, and they have these nonspecific symptoms, and if they actually have a Borrelia infection, those are the patients that have significant need. So we actually have two arms to our study. An arm where we're looking at patients who have a rash, and in that arm we can have a better way of determining if they're infected than if they don't have a rash. And we're looking at both those types of patients to demonstrate the utility and accuracy of our tests. So here's some data from the arm of the study for the patients who have a rash, so report to their doctor with a rash. The gold standard for our clinical study here isn't just whether they have a rash. We know that you can get rashes from other things than a Borrelia infection. It's actually taking a skin biopsy from that rash and then culturing it, and if the Borrelia organism's in the rash, then you know, okay, this patient truly is infected. And then the comparison methods in this study are the T2 Lyme directly from blood, and we're doing the same thing we do in all the other tests. We select for intact pathogen cells with our automated platform and detect if Borrelia is there. Now, our panel includes Borrelia burgdorferi. We also include a Borrelia genus channel that detects a variety of species across the genus. And then we compared a tissue PCR. It's a PCR sample from a tissue biopsy sample from the rash. Seroconversion, that's where you take the sample early and then come back 60 days later and see if the patient's seroconverted. And then what the CDC recommended method for Lyme disease today is a two-tier serology test. And then a blood PCR test. There's several different blood PCR tests that are available today through reference labs. So you can see the data here. T2 Lyme had the best overall percent agreement, best sensitivity or PPA, and specificity or MPA. And what's fascinating here is the whole blood PCR didn't detect any positives in this study. And we continue to see that there's a substantial difference in sensitivity, of course, with a test that doesn't need any sample prep and is agnostic to interference than one that does. The best combination, though, is if you take the two-tier test, combine it with T2 Lyme, that's where you get the most comprehensive performance. So the other thing that's really exciting to us for this panel is the thing we stress a lot about is contamination. We've heard the panel talk about that. If you have organisms that are prevalent in the environment, then your issues with contamination are a lot more difficult. Borrelia doesn't like to live on surfaces. Borrelia doesn't like to live pretty much anywhere other than in a tick or in a mouse, a deer, or us. And so our specificity is extraordinarily high here, which is really important for this type of test. So we're excited to continue to push this forward in our conversation with the FDA and collect our clinical data to help address this really important area of healthcare needs. So to summarize, our tests, as demonstrated by this new product code with the FDA, very, very novel, first in class, first time you ever had FDA-cleared tests for direct from blood for patients with bloodstream infections that don't require an upfront blood culture. We've got great sensitivity performance as well as robustness to interference. And we're really excited. A lot of our efforts focus on helping address the clinical paradigm today to help improve the care for these patients that are sick. And we're excited to also be able to help work with the community of biothreat pathogen detection to help bring a new tool forward there. So thank you for your attention.
Do we have any questions?
Does the T2 aspect of this have any functional role in the PCR that you're doing? Because you said something about normally you wouldn't be able to detect the DNA in the concentrated sample.
So it does from the amount of amplicon that's produced is still dilute. It's not above threshold limits that you need for a light cycler or an optical detector. The other dimension of it is that the target amplicon that's produced is in a sea of non-specific amplicon as well. So a very selective hybridization-based detection method that's triggering the T2 response at very dilute amplicon levels. And so what we've learned with the T2 MR detector is when you have a detector that's just agnostic to matrix effects, a lot of the reagents that all of us work with all the time work really well in complex matrices. actually isn't surprising. You think about why these different biochemicals work the way they do. But it's actually, they just aren't meeting the thresholds of optical detection. Does that help answer your question?
How many, how large can these panels be with your system?
Yep. So the current instrument here, that 13 panel for T2 resistance, that's currently the largest one we've developed. We have some other panels that we're in development, we'll be announcing in the near term, that actually go up to around 40. And so really the limiting factor for our technology is just the disposable and how many discrete tubes that you have that you do your detection on.
Do you need a discrete tube for every
Yep.
member of that panel?
So every reported result has a unique detection chamber in it. And our current, and so that's the difference between each panel, is expanding that number. And so the actual multiplexing capability from the DNA amplification point of view, we've already demonstrated we can go far up into the 40 plus range. Yeah.
You have to have a consumable for each one of those?
That's right. Yep. You have a consumable that has unique wells for each detection well, and so that's an engineering exercise. And we have data that demonstrates we can do that, not on the current FDA cleared instrument.
Okay, I have a question for
Yes.
you. To start off with, 4 mils doesn't sound like a lot of blood, but it actually is a fair amount of blood, especially if you're dealing with neonates, for example. Have you tried to decrease the amount of sample, and what effect does that have on your sensitivity?
It's a great question. Great question. It's funny, the paradigm when we started was blood culture takes two 10 ml draws 3 or 4 times. And we're like, hey, 4 ml is great. You're right on. And for the pediatric patients, that's where the need is really, one could argue, most acute. So we've had a variety of hospitals. There's a few actually I just met with internationally where they've already validated that they're doing direct pipetting into the cartridge for 2 ml volume, and then they're actually looking at loading lower volumes. And this is a QS procedure that a lot of pediatric labs do. And so, the open question is, what's the titer level in there? From our validation point of view, that 2 ml volume gives you down to that 1 CFU per ml sensitivity. But I'm encouraged by the data they're seeing in pediatrics, so that they can go down below that.
Okay, and then you also, in a table on the upper right-hand side, it was one of your earlier slides, you were talking about, I think it was negative predictive value, positive predictive value, and you had a lower level of, or it was sensitivity specificity,
Yep.
lower sensitivity for staph.
That's right.
Can you comment on that?
Absolutely, yeah. That's part of the challenges of doing these prospective studies. We had around 1,500 total patients enrolled, and I think we had about 16 blood culture positives for staph. And so in that case, we had 12 that were T2 positive against the 16 that were blood culture positive. When a second tube was rerun for those 4 patients, 2 of them came up positive. And so I think those 2 were clearly right at the limit of detection of our tests, and we see this with all of our tests where you can get a negative draw and then a positive draw. It's not unlike what you see with culture. The other 2, I think we weren't able to adjudicate, so we just had to report that as our overall sensitivity. And so what we're seeing clinically since the launch of the test is the false negative issue with staph hasn't been an issue. In fact, the big excitement about that is that they're seeing such good performance, they're looking at de-escalating the vancomycin. But really what we need to see, like I mentioned for the Canada study, a follow-on study that shows a really large number of culture positives, where you get in that 100 plus range, and then you can get statistically significant percentages from your prospective study.
Is it 4 mLs per indication on your panel?
No. So it's a 4 ml EDTA vacutainer for everything, all the results that you get. And actually, it's really the active volume for the test is 2 mLs. And that just has to do with the vacutainers that are available. And so the minimum volume that you have to have in your vacutainer to interface with the cartridge is 3 mLs just based on the fluidics.
Okay, let's thank our speaker.
All right, thank you.